Hi, I'm Kathleen Moore. I'm an assistant professor of gynecologic oncology at the University of Oklahoma Stephenson Cancer Center here with Sarah Cannon Research Institute. More excitingly is the ever-increasing number of targeted agents that are being developed, many in ovarian cancer. So these are drugs that in large part are oral drugs. So many times my patients want the oral drug that they get for breast cancer. Doesn't work in ovary, so we can't use that, but there are oral drugs being developed for many cancers that when we get a hold of them for ovary patients actually work pretty well. And so there is a large research interest in developing non-chemo treatments for ovarian cancer so women can be home, not have to come in for IV infusions, take their pill every day, and maintain disease stability for long periods of time. One of the most interesting drugs under development are called Parp Inhibitors. These are drugs that actually first kind of got their big interest in breast cancer, but they are showing some pretty interesting activity in ovary cancer as well, in the recurrent setting, and potentially in the upfront setting. They act differently than chemo. They're pills that you take, and they basically prevent an injured cell from repairing itself, which is how cancer cells live. So there are many reasons a cancer cell is a cancer cell. In a working system, when a cell has damage to its DNA or some other part of it, it recognizes that and it dies, so it doesn't replicate. A cancer cell has some damage to its DNA or many other pathways, but it escapes that, and so it replicates its damaged mutant self, and that series of events continues, and that's sort of one of the ways that cancer tumors grow. PARP inhibitors prevent that, and so they prevent the cell from repairing itself and kind of keep it in that pathway of self-destruction, which is what you want. You want an injured cell to die. So PARP inhibitors are very interesting and under development in a number of tumors, breast being one, but ovary another, and so we're very excited about those. So that's one pathway. Another pathway that's gotten a lot of interest in ovarian cancer is a pathway that deals with blood vessel formation. So we all make blood vessels every day. So if you cut your finger, you need to make blood vessels to heal. It's a part of healing. But tumors trick your body, hijack those blood vessel making pathways to make blood vessels for the tumor, to feed the tumor. So if you can block that, that's one way to attack how a tumor grows and how a tumor spreads. So there's a lot of interest among a number of drug companies in developing drugs that target this blood vessel making pathway. It's called an angiogenesis pathway. One of the first drugs developed and actually FDA approved in other tumors is a drug called Avastin or bevacizumab. That drug has been tested in ovary cancer in 2 big trials, one of which was just published in the New England Journal, and did demonstrate an improvement in what we call the progression-free survival. So from the time you finish chemotherapy until you recur, patients who got Avastin did better than those who did not. And so that was a positive and very exciting trial. The downside is that Avastin doesn't work for everyone, so it probably works for a proportion of patients and probably helps them more than our study showed. Our study showed an improvement in 4 months in aggregate. Probably if you took out everyone for whom the drug didn't work, that amount of time may be longer. If you could select for patients, then the benefit may be bigger. But the problem is right now we don't know how to select for who will benefit from Avastin and who won't. And so that may limit its utilization in the broad population. Unfortunately, it's an expensive drug, and if it works for only a minority, it's hard to justify for the majority, but it's a step in the right direction. That is an IV drug, an intravenous drug. There are a number of similar drugs that are all oral, so in pill form, that are being developed right now in other tumor types, but will probably come over into ovary, that may take the place of Avastin as an alternative that, as an oral drug, may be more financially doable in large number and may even be more effective. We don't know until we test them. But there are a lot of exciting new angiogenesis or blood vessel attacking agents on the horizon, and so that should be really exciting for our patients because they're going to get access to those. And then there are just a number of other pathways that all cancers use, in ovaries no exception, to help the tumor grow and be a bigger, badder cancer. And drug companies are getting much smarter at targeting them, again, with a lot of oral agents. And so these drugs are being developed and at many sites are being made available to ovarian cancer patients through clinical trials in the recurrent setting, but we're seeing some very promising responses. So I think from a treatment standpoint, the future looks very bright for ovarian cancer patients. Of course, the main research emphasis is figuring out who gets ovarian cancer and preventing it. We can build better treatments, but you still are treating patients with a disease that's ultimately going to claim their life. So the best research, of course, would be the one that puts me out of business and prevents this from happening, identifies women who are at high risk so we can do preventative surgeries. Right now, those women, the only women that we can identify who are at risk are those who carry something called the BRCA gene, the BRCA gene. That is a genetic mutation that is passed on in families and places women at risk mainly for breast and ovary cancer, but also some other less common cancers as well. And so if you know a woman has one of the two BRCA genes, you can time when to offer her what's called risk-reducing surgery, which is removal of the ovaries. It's different for each gene. BRCA1, those patients actually have their ovaries out a little bit earlier than BRCA2 because of the risk, the timing, the age risk for developing ovarian cancer actually differs between the two genes. So not everyone has to have their ovaries out in their teen years. Neither of them do actually, but there is some differences in how we offer these surgeries. But the surgeries drop their risk of developing cancer by about 85%. It's not 100%, but you can almost prevent it in that population. BRCA patients only account for about 10% of ovarian cancer patients, so the vast majority of women who get ovary cancer don't have a known genetic mutation. So for the majority of women, we don't have a risk model, unless they just have a profound family history that's not otherwise explained genetically, but that's pretty uncommon. So much of the research now is looking at really genome sequencing, so sequencing the DNA of women who have ovary cancer versus women who don't have ovary cancer and trying to find genetic signals that would identify women who are at risk, not just looking at genes, but looking at all sorts of things in our bodies, protein expression, and other sorts of markers that put together may allow for a screening test, like a Pap test, for example, that would predict someone who has maybe an early ovary cancer or better yet, a pre-ovary cancer, so that she can be appropriately managed before it becomes something life-threatening. But we are far from that. But that is certainly the goal, and there's a lot of effort and thought and brilliant people working on that question. That's the most important goal, is developing a test that predicts it. But we thus far have not been successful.